Hello, everybody. This is the fourth episode of endometrial cancer series. We have already discussed why we emphasize too much on endometrial cancer, because this is the most common gynecological cancer. It's highly associated with obesity, means we can prevent or we can reduce the risk of developing endometrial cancer. We talk about some statistics. The lifetime risk of endometrial cancer, 3%. Lifetime risk of developing endometrial cancer in obese women, 9%, and in Lynch syndrome, 40 to 60%. We discussed the cutoff score of starting investigation for endometrial cancer, 4 millimeter, and I discussed in detail two systematic review from 2010 and 2015, which they concluded the cutoff score of 4 millimeter has got sensitivity of 94 and a specificity of 46, and as a result is a safe number to start or withdraw investigation. In this video, I would like to talk about some numbers again, but not percentage, about the cutoff score that we start investigating in different groups, like women who are taking hormone replacement therapy or women are tamoxifen. Let us start. We know that postmenopausal women with endometrial cancer classically present with postmenopausal bleed. The probability of having endometrial cancer in a woman presenting with postmenopausal bleed is 5 to 10%. But if endometrial cancer is less than 4 millimeter, this probability will drop to less than 1%. How we approach if someone presents with postmenopausal bleed? As we know, back to basics, taking history and physical examination. History, detailed gynecological history, is extremely important. You have to include history of any treatment regarding endometrial hyperplasia, parity, early menarche, the age of menopause, any history of breast cancer, high blood pressure, diabetes, Lynch syndrome, what's the BMI, history of taking tamoxifen, because all of them can be risk factor for developing endometrial cancer. On the other side, any history of taking combined oral contraceptive, as we know combined oral contraceptives have protective effect on developing endometrial cancer. After you have taken your proper history, then we start investigation. Transvaginal ultrasound, we know that is the first step in investigating women who present with postmenopausal bleed, and we measure the double layer of endometrium, and if it's less than 4 millimeter, no further investigation is needed, but if it's more than 4 millimeter, we need to take endometrial biopsy. We talk about women who present with postmenopausal bleed, but what shall we do regarding incidental findings of increased endometrial thickness? I'm pretty sure many times you have received a call regarding a patient had a CT scan or ultrasound or any other investigation for any other reason, and endometrial thickness has come 5 millimeter, 6 millimeter, 7 millimeter with no history of postmenopausal bleed. And then you are wondering, what shall we do? I personally use the cutoff score of 5 millimeter based on a study from UK collaborative trial for ovarian cancer screening, that asymptomatic endometrial pathology was discovered in 125 out of 36,000 postmenopausal women. But what you have to remember, there is no clear guidance. I use 5 millimeter. I know some of my colleagues, they use 8 millimeter if there is no risk factor for endometrial cancer. But I prefer to use, as I mentioned, UK collaborative trial for ovarian cancer screening as my point of reference. But you have to remember, incidental finding of increased endometrial thickness investigation is at the discretion of individual clinician, taking patient preference and risk factors into account. Now, the juicy part that we always forget, which cutoff score we have to use for different patients. The cutoff of 5 millimeter is suggested for postmenopausal women on tamoxifen who present with postmenopausal bleed, not 4 millimeter. Hormone replacement therapy and symptomatic women, we use endometrial thickness of 5 millimeter. The upper endometrial thickness limit for postmenopausal bleed on hormone replacement therapy is 8 millimeter if asymptomatic. Just to recap, postmenopausal women who present with postmenopausal bleed, we use the cutoff score of 4 millimeter. Incidental finding of increased endometrial thickness in asymptomatic postmenopausal, I use the cutoff score of 5 millimeter. We use the cutoff score of 5 millimeter to start investigation, not 4 millimeter if patient is on tamoxifen. And we use the upper limit of 8 millimeter if the patient is taking hormone replacement therapy but has no symptoms and is incidental finding of increased endometrial thickness. I appreciate it's quite too much to take, but there are only 3 numbers to remember, 4, 5, and 8, but make sure you use the right number for the right patient. The other thing, what you have to remember, all those numbers are not applicable if the patient comes with persistent vaginal bleed and negative biopsy. You need to proceed to outpatient or inpatient hysteroscopy, and patient needs to be discussed in multidisciplinary team. Now let's talk about endometrial people biopsy. Let's talk about failure rate, inadequate sampling, and what shall we do in those cases. We know that people biopsy has got 11% failure rates and 31% inadequate sample. There was a study by Van Doorn, found out 6% out of 66 of her patients with insufficient sampling, they had endometrial pathology. 3 of them had endometrial cancer and 1 had atypical hyperplasia. He concluded that insufficient sample and endometrial thickness of more than 5 millimeter should not be reassured. In my own practice, I only reassure insufficient sample if the endometrial thickness is less than 5 millimeter, for example, 4.3, 4.4, and there is no other risk factor for developing endometrial cancer. It's reasonable to reassure and discharge women with insufficient endometrial sample if endometrial thickness is less than 5 millimeter. I hope you enjoyed. Thanks for watching, and leave your comments and I'll get back to you. We carry on with episode 5, 6, and 7. I walk you through endometrial cancer, and hopefully after my last episode, you know what you need to know when you are dealing with a patient who has the potential risk of having endometrial cancer.